We have enough data now to support the idea that steroids really shouldn't be used to treat rheumatoid arthritis unless we absolutely have to. There's still some debate in the community about what constitutes having to, but most people still agree that we do need to use steroids sometimes in RA management. Given that, in RA, we really should be moving towards a stewardship model like we have for antibiotics and opioids. And there are several key principles of steroid stewardship when you apply it to RA specifically. The first one is we need to be using the lowest possible dose for the shortest possible time. So for instance, if you're giving a steroid burst for a flare, we really want to be giving the lowest total dose over the shortest interval that you possibly can as a clinician. The second principle is we want to be looking for effective alternatives when possible. So if a doctor can continue someone on steroids to keep their RA under control, or they could add another disease-modifying medication and potentially taper their steroids, we really are recommending that the doctors add the additional disease-modifying drug and get the patient off steroids if possible. The third principle is doctors want to be monitoring closely for steroid toxicity and counseling patients about the risks of steroids. When we do have a patient with RA who really needs steroids, we need to make sure as clinicians that we know the data around the side effects that those steroids can have. And we're not just assuming that the exposure is safe because, for instance, the burst that we're giving the patient is short or because the patient is otherwise low risk or healthy. We also need to be making sure as clinicians that we have a plan to taper the steroids when they're started. One of the major risks of long-term steroid use is the inability to get people off steroids because of withdrawal symptoms after the steroids are started. And if patients are having these symptoms, we need to be trying to figure out why, rather than assuming that the patient needs long-term steroids because of these side effects necessarily. If we adopt this stewardship model for steroid prescribing in RA, we'll be making sure that clinicians are prescribing steroids when they're truly needed and avoiding them when they are not. And this in turn is going to prevent avoidable steroid exposure for patients and related side effects.